Hello, good morning, everyone. Thank you so much for joining us today. We're really happy to have Dr. Pelak here talking about vision and Parkinson's for this webinar. So thank you, Dr. Pelak, for presenting for us today. A couple of housekeeping things for all of you. The first is we will be holding all of the questions till the end for our Q&A. It just works better this way for a webinar format. And there are a couple of different ways that you can ask the questions. The first option is on your control panel for GoToWebinar. There should be a drop-down menu that says questions on it. You can go ahead and type your questions right in there and they will be sent to me. If it's a technical question, I'll go ahead and answer it. But if it's a question for Dr. Pelak, we'll hold that until the end and I'll announce the question and repeat it back. The other option for you, if you want to ask your question verbally and yourself, there you can raise your hand. There's a raise your hand function on your control panel as well. You can just shoot your hand up and I will unmute you and you can ask your question directly. If you choose to do this, please make sure that your computer is equipped with a microphone so that way we can hear you. There were a couple of questions that were submitted beforehand that we will get to during the Q&A as well. So just so you know that there will be a follow-up email to this webinar that will be sent out tomorrow, and it will include the handouts and also a recording, so you can share the recording with your family members or loved ones if you want them to know a little bit more about vision changes. And I want to also let you know that we have a couple of other upcoming programs that are available to you guys. All of them are online. We're moving all of our programs and services online through May just to keep everybody safe. So a couple of those is our first one will be starting next Wednesday, so a week from today, and that is with Greg Richer. We're going to be having a conversation about how he's developed different ways of kind of tracking his factors, different factors in his life that help him manage his Parkinson's. And there will be 4 sessions of that each on Wednesday from 2 to 3 p.m. We also have a Parkinson's 101 on medications and treatments next Thursday from 4 to 6 p.m. And our last one that we have scheduled currently is a managing stress and anxiety. I know we're all a little stressed right now, so it might be good for anybody to listen in. So that one will be on Thursday, May 14th from 2 to 3 p.m. All of these and any additional programs that we offer are listed in the handout that you can see in your control panel. You can download that there or go ahead and visit www.parkinsonrockies.org/online programs and you can access those there. That list is regularly updated so you can keep up with us. So with that, I will go ahead and transfer over control to you, Dr. Pelak, and we can get going.
Terrific. Thank you so much. Well, good morning, everybody. I'm very happy to be here to share information with you about vision in Parkinson's disease. Unfortunately, I'm not able to have my webcam available so that we can all see each other, or at least you can see me. So I apologize for that, but I'd like to get started and really try to emphasize some of the things that often we are asked, which on the top of the list is, could my vision issue be related to my Parkinson's disease? I'm a professor of neurology and ophthalmology at the University of Colorado Health Sciences Center in Aurora. I see patients at the Eye Center, which is pictured here, the Rocky Mountain Lions Eye Center. But I am a neurologist by training, and my practice is in subspecialty field. An area is called neuro-ophthalmology. And I'm also the PI for the Lewy Body Dementia Association Research Center of Excellence, and Lewy Body Dementia being the type of dementia that occurs with Lewy bodies within the cortex which is a condition very much related to Parkinson's disease and Parkinson's disease dementia. So just to get things started, I'd like to initially just talk about what Parkinson's disease does not cause in regards to your vision. As we age, so many things change about our vision, and so many things change about our eyes that at initial time points when people were trying to understand what Parkinson's disease causes or does not cause, there was a lot of concern that it could be contributing to just the simple things that we know happen with age. So we now have a lot more information over the years to know that any change in your need for glasses, so if you become more nearsighted or more farsighted, this is not related to Parkinson's disease. So nearsighted meaning you have difficulty seeing far, so you're able to see near but not see far, and you need glasses for that. Or farsightedness, meaning you have no problem seeing near or no problem seeing in the distance or far, but in order to see up close, you've always required glasses for such. Those conditions and a change in your prescription is not related to Parkinson's disease. So what about some of the more what we refer to as eye problems related to age? One condition is presbyopia, and that simply means a change in your vision due to age and aging. And otherwise, this is what we all know is a need for readers as we get older. Usually that starts around the age 40 and progresses to the point where readers are required at all times to read anything up close at all. And this is not, again, related to Parkinson's disease. And it's important to keep in mind, because if you're wondering whether or not your prescription is changing or it's getting more and more difficult to read up close because things are out of focus, is that related to Parkinson's? The answer is no. And similarly, for conditions that are age-related as well, and these are cataracts, glaucoma, and macular degeneration. And each of those three conditions occur in different areas of the eye itself. And again, Parkinson's does not hasten the issue associated with those age-related conditions, and it does not cause those. So what does it cause? So we're going to talk about the 4 categories of vision that Parkinson's disease does appear to impact. The first being basic visual function, which I will explain, eyelid function, eye movements, and visual perception. So we're going to go through each of these, and I'll explain what I mean by each, as well as what is the issue associated with Parkinson's disease and each of these categories. So if we talk about basic visual function, this is usually checking your visual acuity, meaning you're reading the eye chart and allowing the optometrist or the ophthalmologist to know what you can see with or without lenses. And that actual task of reading the eye chart does not appear to be affected. And again, your ability to read the letters on the eye chart should not change when you have Parkinson's. But there are other parts of your basic visual function that we often don't think about, because usually when we go to the eye doc, we're really just measuring your distance acuity on an eye chart. So, but there are other parts of the eye that are helping you see and providing that information to your brain in order to do some visual processing. And one is contrast sensitivity, and another is color sensitivity. So what is contrast sensitivity? Well, I put up a chart here, the Pelak contrast sensitivity chart, to help me explain this to you. If you look in the upper left-hand corner, you will see the letters H, S, Z, and those are followed by the letters D, S, N. And if you see the first 3 letters, they are very black against a white background. The second 3 letters, the DSN, are of what we would call lower contrast. meaning the difference between the letters and the background has started to become decreased. So high contrast sensitivity is what you're tested for when you're reading an eye chart, because remember, those letters on the eye chart are black against a white background. In fact, the projection that you're looking at actually has a very light background, and the doctor often puts you, or the technician often puts you in the dark for you to read that. So by putting you in the dark and by having a very bright lit background, this is increasing, making the contrast as high as possible. So we call that high contrast visual acuity. But as Parkinson's occurs in somebody's eye as well as their brain, what happens is their sensitivity to contrast differences goes down, so that when things are of a low contrast, it is harder to read. So if this chart were used to test, which it has been in studies, were used to test somebody with Parkinson's disease and compare that to people without Parkinson's, a person with Parkinson's would have a harder time reading the lighter letters. So the DSN is harder to read. The CKRZVR, which is the second line, becomes more difficult to read, and so on and so forth. So contrast, let me go back a slide. This is the one issue that we're still grappling with, is using slides during webinars. But so the contrast sensitivity, to summarize, becomes lower. So it is harder to see things that are not completely the opposite of the background. And when does that occur? Low lighting. We think of a low lit room, and you can notice that it's going to be more difficult to see where the edge of your bed is compared to a free area around your bed that you might, a pathway that you might use to walk to the bathroom, or anything that's on the floor, a piece of furniture, clothing. Once you're in the dark, that item is no longer easily distinguished from the background. So the time when this becomes very difficult is in dark lighting, meaning anytime something gray against a gray background, as soon as you turn off the lights, it's going to be much harder to see. Okay, what about color? We know that color can also change in Parkinson's disease. And one example of a way to test your color is to use these color plates that we use to identify whether color vision is decreased. And if we check color vision in people with Parkinson's, it's not severe in its absence, meaning people do quite well on some of our basic color vision tests. So the problem is at much lower than what we equate with color vision, or people who are born with color vision loss. So it's mild, but it does change. And so on this slide, I have an example of the number 16, which is different than the background, which is blue, and while the number is in yellow. And over time, when people have more loss of color vision due to aging in general, or to Parkinson's, it becomes harder and harder to see these numbers embedded, which again are similar to the contrast sensitivity. They're differences in hue between the background and the item that you're supposed to identify. Okay. So knowing this, one of the things that people will often ask is, well, why would this happen? Why would the contrast in the color sensitivities change with Parkinson's disease? Well, we believe that the retina has dopamine in it as a transmitter to help you identify information such as contrast and color. And because dopamine is deficient in general in Parkinson's disease, we believe that this may be the reason behind the loss of contrast and color sensitivity. So essentially, dopamine deficiency in the retina. Now, this is not a target of treatment, meaning we don't believe that it is important to add dopamine directly into the retina. We don't have a way to do that, number one, and we don't believe that this is a great cause of disability in people with Parkinson's disease. And so let's talk a little bit more about what this might look like inside the eye before we talk about treatment. I just briefly touched on that, but here's a picture of somebody in a side view, so you can see their lashes. Here's the very front part of their eye called the cornea, and you can see their pupil here, their iris, which is a lightly colored brown. Now let's go into the anatomy of the eye, and the reason I showed you the picture of the person in side view is so you understand what you're looking at here in the eye. And what you can see again is the front part of the eye here. The pupil that you were looking at would be here. The iris is not shown in full view, but on the side, this is where the iris pigmentation would be, right here at this little arrow here pointing to this blue part. And all the other structures are labeled, but what I want to point out is what we call the retina, which sits on the inside of the globe or the eyeball itself. And then we can even magnify that retina to show all the different layers of the retina. In grade school, we talked and learned about the rods and cones. Those are located here. We see them green, red, and blue. Those are rods and cones, and the cones are actually in the dark. Those are rods and cones that are sitting inside the retina that use dopamine as a transmitter to send information through these areas in between, which are oftentimes referred to by other names for different cells. They're going to send that information about the color and the item that you're looking at. They're going to send that information back through the retina into an area called the optic nerve, which is then going to send all of that information to your brain. And so we think that there are some very minor changes that occur in the area of important signaling that relates to contrast and color. So do we need to treat when people have noticeable contrast and color changes? And right now, as I noted, that this is really not a target of treatment because the deficiencies are mild. They're mostly shown by relationships to research studies and outcomes. The time that this can really be a problem is if a person has another condition that causes contrast and color problems, and the ophthalmologist wonders why the person is having so much difficulty. So let's say you have macular degeneration and you have more contrast and color problems than your doctor would expect for the condition that he or she is treating. That may be one time where we lend a hand and let that doctor know that, yes, they have macular degeneration, they have diabetes, and their color and contrast is affected, but on top of that, they have Parkinson's, and so they may have more difficulty with color and contrast because of the Parkinson's. But it usually is not a severe issue related to Parkinson's alone. So should we, when people are coming into our office and noticing that I have macular degeneration and my color and contrast seem to be worse than would be expected, should I'm on a low dose of dopaminergic medications, maybe Sinemet, should I change my medications to attempt to treat the contrast and color problems? Typically we say no, but a short trial, because as you know, within a week or two, you can really understand whether or not Sinemet is impacting a certain function. That can be something that can be tried, and if there is no help and not immediately noticed by the person who's adjusting their medications, then it's good to just go right back to your typical medication regimen. So it's very rare that we ever make a suggestion of a change in treatment or addition of treatment to treat color and contrast. But I did want to bring that up because many people ask about the ability to read an eye chart or color plates. And again, these should not be greatly impacted, only if there are other conditions that impact color and contrast to a greater degree. Okay, so we've covered basic visual function. So let's now talk about eyelid function. And many of you may realize that you have a decreased blink rate, or your care partner or the person you're providing help to has a decreased blink rate. When this happens related to Parkinson's disease, this can lead to dry eye. And one of the things that I like to ask people to consider, and we won't have a feedback in this type of session because we're on a webinar status, so I'll just go through this in a manner that's a little different than I usually do. But what I usually like to ask people is, what do you think the normal blink rate is? Meaning, how many times do we blink a minute? Is it 25 times a minute, 15, or 5? Or is it all of those, because it is very dependent on what you are doing? Now, many times that answer is given as D, and most of the people who will give D will recognize that it really depends on what it is that we're engaged in. Typically, and this is not true for everybody, but typically during conversations, we're blinking at a much more rapid rate than we are when we're at rest or when we're reading. So why should we be aware of this? Mainly is if you are on a computer or you're reading a book, your blink rate may go down to only 5 times a minute. And if you have Parkinson's disease, we have some people that have been witnessed to blink only 1 time while reading. And as you know, what the blink does is provide additional surface moisture, because you're able to move around the liquid tears that we have. In our tear, we have water, which is the majority, about 80%, but there's also oil within our tears, and that oil allows decreased evaporation of the water. So that oil is very important. And then the third component is mucus, which allows the tear to be spread out over the entire surface. And the mucus also provides immune-based responses to anything that gets in the eye that the eye needs to respond to and to prevent an infection, for instance. So blinking is extremely important. The other function that blinking does, besides cover the eye with the tear with those 3 components, is it also allows the glands to secrete more tears. So when you blink, it's a signal to increase tear production and output as well. So imagine while we're reading, if we're only blinking once in a minute and you're reading for 20, 30 minutes, imagine how dry your eye can be and feel while you're doing that activity. Now, this isn't the same for everybody. Some people, in fact, at rest blink more than during conversations. But this is just to give you an idea of what activities could potentially increase your dry eye, which is already a problem even during normal activities because the blink rate goes down. You can think of this as a lot of other types of movements with Parkinson's disease are slow or decreased. Same thing with eye blinking. There is a slowed response, not only during the blink oftentimes can be slowed in a rate, but it also can be just simply the mechanics of the blink can be slowed, or the blink can be incomplete. That's not listed here on my slide, but just know that the blink can also be inefficient, meaning the upper lid and the lower lid do not meet each other. So dry eye is a very big problem and the most common problem in Parkinson's disease, and the thing that we can do the most about. So let's talk about what we can do about it, since it is so very treatable. So one question people ask a lot about is there a way to use dopamine dosing to improve your blink rate? The way we think about this is the same as we talked about with color and contrast. Is, do we know if there's an optimal dose that really helps? Well, we can't be 100% sure, but we do think that if you're having slowed movements of the rest of your body, then your blink rate probably follows and is also likely to be slowed and not efficient. So when you're optimizing your dopamine regimen, whether it's Cinemet or other medications, when you're optimizing those medications for the rest of your body, you're likely also treating your eyelid. But again, we don't have enough strong data to be certain of this. The other thing that I'll tell patients is that you have, if you can remember, because this is not always easy, remember this fact that you are having decreased blink rates when you're on the computer, when you're reading, when you're watching TV, and every so often throw in some purposeful eye closures. Maybe over a period of just 10 seconds, blink strongly or blink 1 or 2 times forcefully, or however you want to increase your blink rate. Do it potentially purposely while you're reading or doing an activity that you know results in dry eye. And then, of course, artificial tears, anything that is meant for re-wetting the eyes, but do not use anything that we consider what manufacturers often write as getting the red out. So that decreases the redness in the eyes. That actually changes the blood vessel caliber in your eye and can some cases contribute to decreased drying of the eye. So essentially use what is regarded as an artificial tear, over-the-counter treatments that really help. And people will ask, well, how often should I use that? Depends on the actual over-the-counter product, so read the product, but generally speaking, those that don't have a significant amount or any preservatives can be used very frequently. And they do sell preservative-free artificial tears, which is what you want to look for if you're able to, which is usually you get 1 drop from each package for each eye, so that you have one little container, you enter a drop in the right eye and the left eye, and then the container gets thrown away. Those you can use very frequently. The ones that have preservatives, you want to make sure you're following what the box says about the frequency, because the preservatives can cause additional problems. We also know that as we age, we're put on a lot of medications that increase dryness. For instance, any type of medication that helps with bladder issues oftentimes can increase the dryness in your eyes. Now, if you need those medications, then you continue with them, but if there's any way to either eliminate or change them in consultation with your physician, then that's something to discuss with them, to say, I've been told that I have a dry eye by my eye doctor, or my eyes are very dry. Can you review my medication list to see if there are any that I can change or alter the dose to help me combat this dry issue problem? Another dry issue problem, which is really for anybody, anywhere, regardless of Parkinson's disease or not, but it is more common in Parkinson's, is lash and lid disease. We refer to this as blepharitis. And this one way to also think about this is not the full picture, but dandruff on the eyelids can clog the glands that allow for good, healthy tear production. And when they get clogged, particularly the oil glands, this can lead to significant dry eye, because if you're not putting out the proper amount of oil, remember that the oil is there to help with reduced evaporation. So if you can imagine that you're producing a lot of watery tears and you're blinking at a good rate, but the oil is decreased, then the tears become immediately absent because of evaporation. So how do you treat lid and lash disease is something called lid scrubs. There are over-the-counter things that you can buy, little kits that allow you to treat your lid lash disease. And these kits are very convenient if it's hard to do it otherwise. But I'm going to describe the easy home remedy, which we often prescribe to our patients, even those with conditions of blepharitis that are quite severe. You take 1 cup of water, 1 drop of baby shampoo. So easy to remember, 1 cup, 1 drop. And you use a washcloth, and you mix around the cup with the drop of baby shampoo, and you simply scrub your eyelids and your lashes to get rid of that dry, dead skin that's accumulating, or any other minor pieces or particles that have landed on your lids. And how often should you do this? You do this at night when you're washing your face, or in the morning when you're in the shower, or at any other time that you're doing your daily hygiene routine. When it gets severe, ophthalmologists can put a plug into the drain of your eye. So in the corner of the eye on the lower lid towards the nose, there's a small little drain that your tears go through so that you can reprocess your tears. There's one method, which is putting a plug inside that punctum, we call it, or the drain, and that allows the tears again to stay in the eye longer. And those punctal plugs do often fall out frequently, so they have to be replaced, and how often they fall out will be very dependent on you, but sometimes they can fall out as frequently as every 1 month to 3 months. So those are some options for treating that dry eye and being aware of what Parkinson's can do. We also have a condition that does not affect everyone, whereas we see the dry eye affecting almost everyone with Parkinson's disease. And it's very common in Colorado to begin with, because the environment plays a role. I didn't speak about that, but obviously the drier the environment, the more difficulty it is to manage your dry eye. But blepharospasm is a forceful contraction of the muscles around the eye. And here we just are showing a picture of somebody with blepharospasm during a forceful involuntary contraction that results in this entire area from allowing you to open your eyes. So here are the muscles pictured below the skin that are involved, and it's called the orbicularis oculi muscle. There are also some muscles on the forehead and between the nose that increase the force of the contraction. And this is treated with botulinum toxin injections. So it's not just your regular blinking or strong blinking, it's really forceful involuntary contraction of the muscles that close the eye, and frequently looks like this during a spasm. So we've covered some of the most problematic conditions, and that really is eyelid function. But we're going to talk about eye movements and visual perception that can impact some people with Parkinson's disease, and some more than others, or some, one way to think about these is this often occurs at more later stages of the condition. So let's start with eye movements. As we know, the eyes are also connected to muscles, just like the rest of your body. And there are some features of the eye muscles that are very different than the muscles in your arms or the legs, but nonetheless, they are impacted by Parkinson's disease. And usually a common symptom of eye movement problems include double vision, but particularly double and blurred vision while reading. And I'm going to explain why. So we call this condition convergence insufficiency. When we go to read, our eyes have to converge in order to focus on the page of a book. So here we have an example of a right eye on the right, a left eye on the left, and then that little sort of upside down V is the nose. So you're sort of having a bird's eye view of somebody's eyes. And you can see that front part of the eye is a half semicircle or almost semicircle. So that's the front part of the eye. And you can see when this person is focusing on the book, both of the eyes are sort of turned towards each other. Well, when you have convergence insufficiency, which means inability to converge the eyes or move the eyes towards each other, what happens to your focus is your focus becomes further away. So instead of focusing on the X, you're able to see things at a distance in clarity, but not close up. So oftentimes, even when you have readers on and you've gone to the ophthalmologist or optometrist and they are saying that your prescription is correct, There's no reason for you not to be able to see at near, because your readers are great, your glasses are perfect, so I'm not really clear why you're not able to see. Your eyes look completely aligned, they're moving properly, so I don't know why you're having double vision or blurred vision while reading. We often hear this from patients. Over the years, optometrists and ophthalmologists are beginning to recognize this as a condition related to Parkinson's disease. And this has a lot to do with their own education, as well as movement disorder specialists and neuro-ophthalmologists, educating optometrists and educating the ophthalmology world about convergence insufficiency associated with Parkinson's disease. So again, just to demonstrate, the eyes are turned inward. When we go to read up close, we call that convergence. But if there's insufficient convergence, your eyes are focusing too far away from the book. It doesn't matter how much power you have in your readers and how appropriate your eye physician has given you a prescription, how appropriate the prescription is. It's because your eyes are not converging properly to do the proper focusing. So what do we do when we discover this? It's very treatable. We typically put a pair of prisms into your lenses, and we can start off by using what we call paste-on prisms. These are prisms that can be ordered by the optician, optometrist, or ophthalmologist's office. You cut them out to fit onto your glasses so that you can try to read with your readers and prisms on it. And if this solves the problem, then you know it's convergence insufficiency, and you can get these prisms ground into the lens, meaning the lens itself can have the prism in it, and you no longer need this plastic paste-on prism. And it's much easier to see without the plastic coat on that you use to just determine whether this solves the problem. We do know there is evidence, unlike the other conditions I've spoken about, that optimizing your dopaminergic medications can help your convergence. So again, if this is a major problem, you're also having slowed movements or other issues, optimizing your dopaminergic medications will help. So this is something I always talk to people about when they present with convergence insufficiency. It's not just about the prisms and doing things that change your prescription that help. Really need to optimize your dopaminergic medications in that case. Unfortunately, it's rarely useful to do eye exercises, which means practice converging. The one time that we see that this helps is after a condition such as a traumatic brain injury, that some recovery will take place with therapy by practicing eye exercise. This does not appear to be the case for Parkinson's, even though physical activity definitely helps with other types of movement. This doesn't appear to be very helpful with convergence insufficiency due to Parkinson's disease. Well, what do we do if these things don't help? We oftentimes, and this is probably one of the most important things that we do to get people to function while reading, is we use separate pair of reading glasses and a separate pair of distance glasses. People with progressives, trifocals, bifocals, those are very difficult to get your eyes into the proper location when you have Parkinson's disease. These require very minor motor movements of the eye muscles, and it can be very difficult. But there's always hope that you don't have to get out of your progressives or trifocals or bifocals initially. So those are things that you need to initially discuss with your eye physician. Is I think convergence insufficiency is becoming a major problem for me, and should I go into separate glasses, or can we work with my current glasses so that I can stay in bifocals and put the prism only in the bifocal portion, for instance. But a lot of times we do need to take people out of their progressives if they're going to try to read. Okay, so now we're going to talk about the very last subject. I'm going to just touch on it very what I might call is in a superficial way, because it really is a topic that might deserve a full hour on its own. But this is one of visual perception. And because the areas of the brain are involved in a lot of activities that have to do with vision, Parkinson's disease can cause visual perceptual problems. So let's talk about some of the very basics, and I call these just the facts. First, it can be a sign of cognitive impairment or dementia, and it actually can be the very first sign of that. And we'll discuss what visual perception is in the upcoming couple of slides. It can be very subtle, meaning on first go, you may discuss this with your provider, your movement disorder specialist, or your neurologist, and suddenly you realize that they don't really understand what it is that you're describing. So it can be very, very subtle and be difficult for the provider to know that what you're describing is actually a visual perception problem. And it oftentimes, because of that, it can be mistaken for the need for new glasses. And again, we're going to discuss what visual perception problems are. And it can be mistaken for any other symptom related to an eye disorder. So people might assume that it's because of the macular degeneration or the cataract that you have, when in fact it's really a problem with the brain's ability to process visual information. So what are some of the most common? Because again, as I mentioned, we could talk about visual perception really for an entire hour. So what are the most common conditions of visual perceptual problems? At the top of the list are what we call visual illusions, which is mistaken appearance for what you're looking at, and it's somehow distorted, whether it's distorted in its actual physical appearance or whether it's distorted in its your understanding of what you're seeing. We refer that to as a visual illusion, whereas a visual hallucination is seeing something that is not actually there. And again, this is very common in Parkinson's disease, and visual hallucinations are so common that we don't use visual hallucinations as a means to determine whether somebody has potential cognitive impairment, because visual hallucinations are not always a sign of cognitive impairment. So I don't want you to equate those two, but they are more common in people who have cognitive impairment or dementia. And then second is depth perception impairment. And depth perception impairment can cause problems stepping off of a curb. It can cause problems reaching for an item, or even when you go to walk up the stairs, putting your hand in the proper place where the railway is. And then, of course, some visual hallucinations can be very minor and not concerning, but others can be very bizarre, like seeing, in the example shown here is seeing a giraffe in the middle of the street as you're driving or when you're a passenger. And these can be obviously very, very disturbing. So let's talk a little bit about visual hallucinations. As I mentioned, this is not always associated with cognitive impairment or with dementia. 1 in 5 people at the onset of Parkinson's disease can experience some type of visual hallucination. Because of its ability to be treated and because of its ability to impair your function, you should never worry about bringing this up to your neurologist or to your primary care provider, and go armed with the knowledge that it's common and it does not mean that something is going wrong with you psychologically or with your cognition or memory, because it is so common with Parkinson's disease. But understanding that it's common and that is not a sign that you should not tell people about because of the fears that it may provide to you or your family. Going with this knowledge about its common presentation and that there's things that we can do about it is very important. So one of the first things that we can do about visual hallucinations is taking a look at your prescriptions, because all of these listed here are all medications that we use to help treat Parkinson's, and they have been associated with increased risk for visual hallucinations. This doesn't mean that you should stop any of these dopamine agonists, amantadine or monoamine oxidase type B inhibitors or anticholinergics. This does not mean you should stop these medications. This is really a means to have an open conversation with your physician about whether you can alter how you're given or switch to another one that's less likely to cause visual hallucination. And a movement disorder specialist who's a neurologist will be much more familiar with the ins and outs of how to adjust these. So sometimes a referral to a movement disorder or Parkinson's disorder specialist can help. Don't need to necessarily have to go and see them and continue, and continue to see them. But sometimes if you feel like you need a little extra help and you're not getting there, asking for a referral to a movement disorder specialist may be one approach to really help with solving visual hallucinations. And there's many other things that you can do, including using medications to decrease the hallucinations. So why do people experience depth perception? Well, it's a little bit, as I noted, beyond the talk to discuss this, but we are going to touch on it so you just have a general sense. We know that the back part of the brain is very important for you to understand what you're seeing. Okay, we call that area the occipital lobe, but it also involves part of the parietal lobe and part of the temporal lobe. These areas are very important for monitoring everything that you're seeing and determining depth. And these areas have strong connections with the basal ganglia, very strong connections, so that you can make motor movements appropriate to what you're seeing. So if you're trying to avoid an object in the street or trying to walk around an object, your motor system has to be connected to your visual system in order to do that. And just know that these networks of connection are changed related to Parkinson's, and therefore there's a decreased ability to understand and see depth. So how do we treat visual perception problems when they occur? Well, definitely one size does not fit all. We have to optimize your vision. So if you're experiencing double vision, this is going to be a severe problem for your depth perception. If you have cataracts and you're not getting discrete good information in, and you're adding to your problem with contrast sensitivity and color, well, we need to optimize your vision by removing your cataract. So those are important factors in making sure that the information that's getting to the brain to allow for communication is optimized. And the same with medications. And in the end, if these are not useful, we can always use a medication that can help suppress hallucinations or use a medication to boost neurotransmission in the brain when these types of things happen. What are some additional tips for visual hallucinations? Avoiding isolation and avoiding lack of visual stimuli. So sitting in a dark room, especially at night, not able to see a lot of objects around you can increase visual hallucinations. Interacting and talking to people and staying active, very important for decreasing visual hallucinations. Doesn't always work, but it is one tip to consider when hallucinations become a problem. And increased lighting, again, increases visual stimuli, increases your ability to see things better. Report this to your neurologist, because there are many things that can be done with visual hallucinations. And consider treatment, which includes medications to help suppress the hallucinations. So just to summarize, we've talked about the basic visual function, which includes decreased contrast and color sensitivity, but these are not usually a major problem. We've talked about eyelid function. Decreased eye blink rate is probably the biggest issue, resulting in dry eye, resulting in blurred vision and difficulty reading. Contributing to difficulty reading are eye movement problems called convergence insufficiency, or bringing the eyes together to focus. Also a major problem and can disrupt ability to read. And then visual perception problems, which mainly occur related to depth perception, but visual hallucinations and illusions are also part of perceptual issues and have many treatments and many treatment approaches. So remember to not fear talking about this, and not fear that you have a problem that others don't, or that something's happening that you don't want to reveal. Always talk to your neurologist or your family members about these symptoms, because they are very treatable and your function can truly improve. So just knowing is really the first step, because sometimes, as you've probably learned, you're the one that has to sort of train or educate others that are taking care of you. And this may involve just care partners, or this may involve simply the physician that you're seeing that has less knowledge about this than you do. And by bringing it up to them, then they can learn and become educated, and that will probably help the next patient down the line, as well as you, for instance, that physician or eye care provider sees. So now I'd like to, again, thank everyone for their, first for the invitation, and secondly for sitting through a seminar during this time that I know is very difficult for family and very difficult for friends, and we all are in this together. And I hope that this has taught you something that allow you to improve your function. And I'm happy to stay and hear any questions that you may have. And again, the University of Colorado Health Center is working hard to study these conditions and hopefully improve function for people with Parkinson's and Parkinson's related disorders now and in the future. So thank you.
Great. Thank you so much for that awesome presentation. I always love learning a little bit more.
Of course.
Yeah, so we do have a couple of questions that were submitted before the actual presentation, and it actually looks like we have somebody who raised their hand. So let's address them first. Let's see if I can find my. All right, so it looks like Elaine has her hand raised. Elaine, I'm gonna unmute you and you can go ahead and ask your question.
Thank you for the great presentation. This has probably been one of my biggest issues, and I am working with your cohort, Dr. Havasworth, in your office, I think in your building.
Yes.
And my neurologist had sent me your direction, but I ended up with him, and he's been great to work with. I am now understanding the convergence insufficiency because I don't read books. I have to do audio books. I have so much stress on my eyes. I do have prisms, but I don't, my second set of glasses, I'm not sure if those are correct because I just cannot read with those. I actually have a third pair of reading glasses. And I guess that's probably my question. Can he help me? Because I have prisms in my glasses with the prisms for reading glasses, or how does that work? I talked to him on Wednesday virtual. And so I will have some good questions for him.
Absolutely. So one of the things that we discover over time, which is really, there's not a simple test, it's mostly what you're telling us. We sometimes discover that, okay, we can no longer use, as we talked about, the progressives, the trifocals, the bifocals, and unfortunately, some people will actually need 3 pairs of glasses, one that helps them sit in a car to look out in the distance, one that allows them to watch TV or be in a theater, and then a second pair for computer distance and a third pair for reading. It can be very, very difficult to get used to that, but sometimes we discover that even with prisms in our lenses, it's just not, you're just not able to accommodate all the different distances in one pair of glasses. And that could be what's happening to you, although it would have to be a trial and error, meaning you could have multiple different types of lenses tested at different distances for you to figure that out. Does that help?
Yes, I have a pair of glasses with prisms for distance. I have a pair that I sit at the computer, but that pair at the computer that I use, I absolutely can't read with it. It's too much strain on my eyes. I've got to have something closer. So
I see.
do I
So you can see the computer, you can see the computer with the computer glasses, but then when you go to read, you can't.
Right, right. And
okay.
Go ahead.
I was going to say that sometimes what we'll do in that situation is instead of the bifocal having distance near, we'll have a pair of so-called bifocals that are computer and reading.
Whoops.
So again, the lower level of your lenses will be for reading, whereas the upper 3/4 will be for the computer screen. So sometimes they can alter what they do with the prescription so that you have one that can see computer and near, but it would be, you know, no good for the distance, of course. And then in that case, you can put prisms of different strength for the reading part versus the computer part. Does that help?
Yes,
Did we
it
lose you?
does.
Okay. Okay, good.
No,
Good.
my clock was a ticking and ringing, and I think you might have been hearing, so I shut myself off. Yes, thank you very much.
Okay. Okay, perfect.
Great. Thank you so much, Elaine. We do have a couple of other questions here from before. So let's go ahead. So this question comes from, let's start with from Marjane. Her question is, how does a practitioner get feedback during eye tests from a person with dementia? Should a person with dementia have cataract surgery?
Very, very good questions. So it can be very difficult when we see a person with dementia and we're trying to test their eyes. However, there are techniques, particularly now we have machines that allow us to designate what the person's eye length is and then turn that eye length in using calculations that are related to age, turn that eye length, age, and then calculate what their prescription should be. However, as you know, to really come up with a detailed prescription, we do need feedback. We do need someone to say, no, that's a little too strong, or that's just right. But at least you can get to what I would call very, very close, appropriate prescription. And sometimes we have to use nonverbal signals, such as when a person is putting their glasses on to look at something and they immediately take them off. That may not be just a behavioral problem. That may be, I don't like these glasses, they're not working well. So you can use those types of clues. Again, that it is more of a hit or miss, but we do have tools in offices that prescribe lenses that can get very close to the prescription. And then second, cataract. Now, this is a very difficult decision to make, because oftentimes we're not sure whether the visual function will really improve for the benefit of the person if their cataract is removed. So often it can take two physicians, one a cataract surgeon, to say that if the person had no dementia, this is definitely a cataract that I would remove. Once you have that, you can then discuss with the dementia physician, whether that's the neurologist or the movement disorder specialist or a neuro-ophthalmologist. You can then discuss, do you think there is visual function that is being impaired by the cataract? So is the brain's visual function to the point where if there was better vision information coming in, they would do better? Because there are times where we say, because of the brain's vision perceptual problem, it doesn't do any good to put the person through a cataract surgery. So that is a very good question. It usually, I would say, in most circumstances, take two physicians, but oftentimes the cataract surgeon can also make that decision very quickly as well.
Gotcha. Great. There were a couple of questions around cataract surgery, so I think that will help. The next question, let's go with, so my symptoms over the last 8 years have been mild and not very progressive. Can I expect this pattern to continue for a long time?
So what the first half of the question was, can you say that again?
Yeah, sorry. So the question it comes from Warren, and his question is, my symptoms over the last 8 years have been mild and not very progressive. And so he's asking like if that progression is going to continue for a long time.
Oh, I see. Okay. So what is the course if somebody has a mild Parkinson's symptoms, whether they're visual or motor or other non-motor features of Parkinson's, will they continue to progress slowly? Generally speaking, the answer is yes, that we know that with Parkinson's disease, our symptoms do progress over time. If they don't progress, then typically you may have a Parkinson's related disorder, meaning sometimes people can have minor small strokes in the brain that imitate Parkinson's, or you can have medications that are causing a Parkinson's-like condition. Those are not typically progressive, but anybody with a diagnosis of Parkinson's disease will show progression over time, regardless if your symptoms have been only mildly progressive. I hope that helps.
Yeah, gotcha. And then let's go ahead. We'll go with one more question and then we can wrap up here. The last question is, Parkinson's disease correlated significantly with retinal puckers?
Oh, very good question. So no, the retinal pucker, the most common cause of retinal pucker, it really is aging. And the second most common is when you're very nearsighted. And that's because the vitreous, the jelly that's inside the eye, that changes as we age. And when it changes, it oftentimes, we hesitate to use the word detach because this isn't a retinal detachment, so I'll say separate. So oftentimes that jelly separates itself from the retina structure itself. And when it does so, it can leave a pucker. And that's just more commonly, a more common occurrence to happen in people who are very nearsighted and in people as we age. So no, macular pucker is more of an age-related or a high nearsighted related condition. But very
Great,
good question.
great. Thank you so much. So
Of
I think
course.
we'll go ahead and wrap up the webinar for now. I just want to send out a quick reminder that there are handouts available and there will be a follow-up email with those handouts and a recording of the session available tomorrow. It'll be sent out tomorrow. And I believe that's all we have for now. So thank you again, Dr. Pelak, for coming and speaking with us. And
My pleasure.
yeah, and I hope everybody stays safe and healthy.
Stay well, everyone. Bye now.
Bye.